Ocular anesthesia can be classified as retrobulbar, peribulbar, subtenons, subconjunctival, and topical. Of these, among the injection anesthesia techniques, peribulbar anesthesia has become popular because of its safety and efficacy. Peribulbar anesthesia can be transcutaneous or transconjunctival. The site of the transconjunctival peribulbar injection can either be infratemporal or medial. The medial orbit is the safest location as it has no major neurovascular bundles. The medial peribulbar is further classified based on the injection site as median peribulbar, which is the medial most injection technique, and medial to the caruncle. The true caruncular anesthesia, where the needle passes directly through the body of the caruncle, and the transcaruncular, where the injection site is lateral to the semilunar fold. In this video, we describe the technique of true caruncular anesthesia and its advantages. The caruncle, from the Latin word caro, means flesh, and it is an ovoid fleshy body about 5 mm in height and 3 mm in breadth, situated in the lacus lacrimalis, and harbors skin elements such as hair follicles, sebaceous glands, sweat glands, and accessory lacrimal tissue. It is bound by the plica semilunaris temporally and by the medial canthal tendon nasally. The few fine hairs on the caruncle are believed to filter debris from the lacrimal fluid passing to the lacrimal canaliculi. The injection technique is easy. After instilling a drop of topical anesthetic, in this case proparacaine hydrochloride, the lids are separated with the non-dominant hand of the surgeon to visualize the landmark, that is the caruncle. A 30-gauge needle mounted on a 5 ml syringe was used to inject the anesthetic. With the eye in primary gaze, the needle was advanced through the middle of the caruncle, perpendicular to the sagittal plane for half the length of the needle and slightly directed medially to go full length of the needle, approximately 13 millimeters. The first injection was 5 ml of 2% lignocaine with 1:1 lac adrenaline and 0.75% ropivacaine mixture. Hyaluronidase was added to the lignocaine mixture to enhance the spread of the anesthetic. After adequate ocular massage to achieve hypotony, a second injection of 2 ml of ropivacaine alone was given. The second injection and supplemental injection, if needed, were given using the same technique. Patients undergoing vitreoretinal or combined cataract and vitreoretinal surgeries at the end of the procedure receive 2 ml of ropivacaine injection for prolonged anesthesia during the postoperative period. Caruncular anesthesia was used in our practice for the past 2 decades and has been found to be safe and effective. The caruncle has extensive attachment to the lower lid retractors, the medial rectus capsulopalpebral fascia, the medial check ligament, and the Horner's muscle. It is separated from the bulbar conjunctiva by the plica semilunaris. The connective tissue in the stroma of plica semilunaris is much denser than the surrounding bulbar conjunctiva and has tight collagenous fibers. The presence of fibromuscular attachments and facial septa under the caruncle, along with its separation from the conjunctiva by the plica semilunaris, prevents chemosis and subconjunctival hemorrhage in caruncular anesthesia. Caruncular anesthesia, thus, is superior to subtenons anesthesia, especially in combined cataract and vitreoretinal surgeries. Because subtenons anesthesia involves a conjunctival incision to access the subtenon space for injecting the local anesthetic via a blunt cannula into the subtenon space, most of these cases will have significant subconjunctival hemorrhage and chemosis. A needle passing through the caruncle will enter the peribulbar space. Injections through the semilunar fold or lateral to the fold may result in inadvertent placement of the needle into the subconjunctival space or the subtenon space, resulting in subconjunctival hemorrhage or chemosis. Because the caruncle is bound by fibrous tissue separating it from both subconjunctival and subtenon space, there is less chance of chemosis or subconjunctival hemorrhage, and the site is farther away from the globe as well as the medial orbital wall. and there is lesser risk of globe perforation or damage to the orbital wall. Vitreoretinal surgeries and combined cataract and vitreoretinal surgeries are of longer duration compared to small incision cataract surgery or phacoemulsification cataract surgeries. Caruncular anesthesia achieves excellent akinesia and analgesia for an adequate duration, even in such cases where the surgery is of a prolonged duration. Another advantage of caruncular anesthesia is its ease of supplementing the anesthesia if required during the surgery, as seen here during a 23-gauge vitrectomy. Our experience with caruncular anesthesia tells us that it is an easy, safe and reliable option for local anesthesia for cataract, vitreoretinal as well as combined cataract and vitreoretinal surgeries.